Hi, I'm Mark Cleaver. I'm from the University of Wisconsin, where I am a professor of radiology. Today I'm going to talk about sonographic findings in first trimester pregnancy, both abnormal and normal findings. Well, I'll take up the topic of sonography of first trimester pregnancy in four different subtopics: approach, landmarks, signs, and abnormal early trimester pregnancy. First, with regard to the approach to diagnosis, there, as many of you know who do ultrasound know, there are two ways of looking at the female pelvis, both the transabdominal views and the endovaginal views. I believe that we should be using both because in many ways they are importantly complementary. Endovaginal views provide high-resolution detail, and these are the mainstay of diagnosis, but transabdominal views are often indispensable for seeing large or displaced abnormalities, and also for getting a sense of how much fluid is in the abdomen or pelvis. Here's an example where this sort of transabdominal view was critically important in diagnosis. This is an endovaginal view, of course. And this is the outline of the uterus. Inside the uterus, you'll see that there's no intrauterine pregnancy within the endometrial stripe. And there is, posterior to the uterus, all this echogenic material, which is somewhat amorphous. From the transabdominal view, it becomes quite obvious that here is the uterus and that there is a large amount of blood that is sitting right on top of the uterus and creating that low-level and medium-level echo pattern that we saw on the earlier image. This, which was difficult to perceive from the endovaginal view, is quite obvious on the transabdominal. The other thing that's important in the approach to first trimester sonographic diagnosis is putting this in the context of the beta-HCG, or the serum or urine pregnancy test. To remind you that there is a somewhat confusing history to the beta-HCG levels. Most places now operate on the third international reference preparation, and so a positive test will be about 100 milli-international units per milliliter. As I was just saying, there is confusion. There's a first, second, and third reference preparation. I think most people do use the third at this point. This gives some of the values by way of comparing the second and the third international standard. The most important number in this chart is this one right here, and that is the level of the beta-HCG at which you should see a gestational sac, and that should be about 2,000. And I'll talk a little bit about why that's important when I talk about ectopic pregnancy. So let's say you had no intrauterine pregnancy. This is, of course, the uterus again. The cervix would be over here. No intrauterine pregnancy by endovaginal imaging, and the HCG level is less than the threshold at which we would expect to see a gestational sac. Well, the differential diagnosis then would be, the primary consideration is that there's an early intrauterine pregnancy before we can see it. Ectopic pregnancy, of course, has to remain a possibility, as does recent abortion or tumors. But if you have no intrauterine pregnancy by endovaginal imaging, but the HCG level exceeds the threshold at which a gestational sac is seen, it should be seen. Here again is the uterus. There is the endometrial stripe. If there is no intrauterine pregnancy at that point, then ectopic pregnancy has to be the leading consideration. The other possibility would be recent abortion, maybe a tumor that elaborates HCG, or false elevation of tests. Remember that the HCG level, just like any test, can have a certain number of false positives and false negatives. So if you have an HCG level, you can follow that over time, and this is what they do. The normal doubling time of the HCG is about every second day. If there has been embryonic death or recent abortion, then the HCG level will decrease abruptly. If you have retained products or ectopic pregnancy, the HCG level decreases slowly in some cases, and in other cases of ectopic pregnancy, the HCG level will increase more slowly than would be expected with a normal intrauterine pregnancy. All right, we'll talk next about landmarks, certain anatomic landmarks that you would expect to see at certain stages of development in the first trimester. We'll talk a little bit about gestational sac, the yolk sac, embryonic pole, and finally some anatomic structures that you should be able to see. Gestational sac is the first sign of pregnancy. It's not a specific sign, however. What you often see is a little cystic structure that is embedded within the decidua without any clear identifier as an intrauterine pregnancy. Indeed, some people have described small cysts within the endometrium as evidence for ectopic pregnancy. So this sign, though present, is somewhat nonspecific. The first really specific sign, and a sign of considerable use, is the so-called double decidual sign. Fundamentally, what is being seen here is that the decidua on one side of the uterine cavity is separated from the decidua that is surrounding the gestational sac. So this would be the gestational sac here. It's separated by the uterine cavity. So this is the uterine cavity right there. And it is this crescent that you're trying to see, you're trying to identify, because that's what gives rise to these two echogenic arcs, or this double decidua sign. Here's an example of it. This is an early intrauterine pregnancy. You can see one decidual line here, that's decidua capsularis, and another decidual line here, that's decidua parietalis, and the separating hypoechoic arc or crescent is the uterine cavity itself. So that's the double decidual sac sign, or the double decidual sign, and this, of course, is the gestational sac right there. There are lookup tables that correlate the gestational sac size, or the mean sac diameter, to gestational ages. The relationship is approximately estimated by adding 30 to the mean sac diameter. Of more importance is this number here, is that the mean sac diameter increases about 1 millimeter a day for the first 8 weeks. And that's going to be an important number in determining what length of time you might choose to follow up a case by ultrasound. Here's an example of a mean sac diameter measurement. It's a fairly crude measurement. It's simply measuring the length and the width and the transverse measurement and dividing by 3. The yolk sac is the first very specific identifiable structure within the gestational sac, and absolutely confirms an intrauterine pregnancy. There are numbers that correspond to what is considered a normal yolk sac. In general, the normal yolk sac should be less than about 6 millimeters. The number in the literature is 5.6, but realistically 6 millimeters is the number you should probably work from. Here's an example of the yolk sac in a twin pregnancy. You can see two gestational sacs here, and if you look very carefully right here and right here, you can see the thin membrane that outlines the circular yolk sac. Here, to remind you, the yolk sac is an extra-amniotic structure. This is the yolk sac here in this pregnancy, and it is outside the amnion, which is shown here. So this is the amnion. The yolk sac is situated outside of that in the chorioamniotic space. So abnormalities of the yolk sac, well, it can be too big, that is greater than 6 millimeters, and it can be too small. If it is thick, irregular, dense, sometimes referred to as the calcified yolk sac, that too is associated with embryonic death and fetal anomalies. Here is an example of a yolk sac that is too large. Here's the embryonic pole right here, and outside of the amnion is this very large yolk sac here, and measuring in excess of 6 millimeters in an abnormal size. Here's an example of the calcified yolk sac. Here is the fetus here. You can see from here to here. And this is the yolk sac to one side of it, and you can tell right away that that is very echogenic and small. And of note, you do not see a very distinctive shadow from this. Nonetheless, this is you often do not see that very weak shadow from it, but that should not dissuade you from making the diagnosis. Here's an example of a yolk sac that is crenulated and irregular. The next structure that you will see in early pregnancy is the embryonic pole. The embryo is evident at about the 5th menstrual weeks, and you will see in cardiac activity by about 5 millimeters. Now, this in the literature is somewhat variable on this point. 5 millimeters for a crown rump length to see a heartbeat is a very conservative limit. In fact, you often see a heartbeat before you even can discern an embryonic pole. But certainly by 3 millimeters and certainly no more than 5 millimeters, you should certainly see a yolk sac with a heartbeat in the embryonic pole with modern equipment. Here's an example of an embryo that now is 18 millimeters of crown rump length, which is well above when we should expect to see the heartbeat. Anatomic structures appear in certain predictable times. Limb buds appear about 8 weeks. The mandible and maxilla appear about 10 weeks. This is quite a useful number because if you have trouble making sense of some of the fetal biometry, if you do see calcification of the jaw, the mandible and maxilla, then you know the fetus has got to be at least 10 weeks of age. Here's some scanning electron micrographs of the developing limb bud. It's, I thought, interesting. You see that the fingers are sort of sculpted from the early formation of the hand by a process of cell death to produce these 5 fingers and 5 digits. Here's an example of ossification or ossification of the mandible and maxilla. You'll see it right here. That's the mandible and maxilla. This is the fetal head here, fetal abdomen here. And if you see ossification of the maxilla and mandible, you know that the fetus has got to be at least 10 weeks gestation. This is a staining of a fetus at 14 weeks. And what's impressive about that is that you go from some of the early ossification, and in approximately a month, you get ossification of nearly all the bones of the body. Notice that there is ossification of all the small bones of the hands and the feet, as well as, of course, the major bones of the body. A couple other anatomic structures of some usefulness is the rhombencephalon, which is visible about 8 or 10 weeks. This is an important structure to recognize because if you're not familiar with it, it can look for all the world like an abnormal cyst or even a defect within the fetal or embryonic skull. But it is in fact a normal structure. Midgut herniation occurs between 9 and 11 weeks, so be very careful about making the diagnosis of omphalocele before about 12 or 14 weeks. And then there's the falx and the choroid plexus, which appear about 9 or 10 weeks. Here's an example of the developing embryonic brain, the rhombencephalon. Notice how in this area here, it looks as though the embryo has a defect in the head. This is the area of the head. This, of course, is the body here. And then there's this apparent large defect. That is the normal developing embryonic brain and should not be mistaken for pathology. Here's an example of mid-gut herniation into the base of the cord right here. This, of course, is the embryonic head. This is the thorax. And there is the herniation into the base of the cord. If this fails to retract back into the abdomen, would constitute an omphalocele, but at this early stage, it is not possible to tell the difference. And the diagnosis really needs to be deferred till 12 or 14 weeks. Now I'm going to talk about a whole set of signs that indicate abnormality in early pregnancy, and then talk about how these are applied. If you have an ultrasound scanner that does not have an endovaginal or transvaginal probe, if you see the gestational sac transabdominally, this is by transabdominal scanning, the mean sac diameter should be visible, or I should say the yolk sac should be visible at a mean sac diameter of 20 millimeters or more. And an embryo should be visible at a mean sac diameter of 25 millimeters or more. So those are useful indexes or rules of thumb. If you have a scanner that does have endovaginal capability, then the numbers shift downward. At a mean sac diameter of 8 millimeters, you should see a yolk sac, and a mean sac diameter of 16 millimeters, you should see an embryo. Other signs, strong signs of abnormality, are a crown rump length of 5 millimeters or more without a heartbeat, or a very slow heart rate. Heart rates below 100 beats per minute are very bad. Heartbeats below 85 beats per minute are virtually always catastrophic. There is a phenomenon known as first trimester oligohydramnios. Basically, this means that the embryo essentially fills the very small mean gestational sac. There is actually a number that you could generate, but most people just subjectively assess how much fluid is around the embryo. And then there is an important sign called the empty amnion sign. That is that the amnio is fully formed and apparent, but no embryonic pole is evident. Then there are signs of abnormality that are somewhat less strong. That is, there's the large yolk sac, which we mentioned, the calcified yolk sac, and the low HCG level for mean sac diameter. Then there are signs of abnormality that I consider weaker. These are weaker primarily because they are more subjective and more difficult to identify. An unusually large gestational sac, or a thin decidual reaction. These things are hard to judge. The irregular margin of the gestational sac, or low implantation of the sac, unless that sac is in the cervix, and then that's a very strong sign of impending abortion. So how do we apply these signs for diagnosis? We'll take up several topics of abnormal first trimester pregnancy, blighted ovum, embryonic death, abortion, extrachorionic fluid collection, gestational trophoblastic disease, and ectopic pregnancy. Blighted ovum is also called an embryonic pregnancy. Basically, what has happened is that the gestational development is arrested before the embryo forms. There's a large, what you will see by ultrasound is a large empty gestational sac, and the differential diagnosis would be early IUP or pseudogestational sac of ectopic. This is what it looks like, the large empty gestational sac. And this is where those numbers about when you should see a yolk sac or an embryonic pole become important. Since this is an endovaginal scan, we would expect to see the yolk sac at 8 millimeters and an embryonic pole at a mean sac diameter of 16 millimeters. So this is the large empty gestational sac here. So as I just said, you need to compare the mean sac diameter to the presence or absence of the yolk sac or an embryo. This is also where the empty amnion sign becomes important, because if you see a formed amnion and no embryonic pole, then that's the sign of arrested development of the pregnancy. Then you can also look for discrepancies between sac size and HCG level. And then there's an abnormal appearance of the sac, and these are some of those signs that are somewhat more difficult to apply: weak decidual reaction, irregular sac shape. Here's an example of the empty amnion sign, large gestational sac demonstrated here. And then there's the amnion, fully formed. You can see it as a thin membrane, a fully formed amnion, but no embryonic pole. And in that case, you can be certain that this is an evidence of a blighted ovum. Embryonic death. Embryonic death is defined as the absence of cardiac activity when an embryonic pole is visible by transabdominal, or when the embryonic pole is visible but greater than 5 millimeters and shows no cardiac activity. The inverse of that is also important, that if you have a crown rump length of less than 5 millimeters and you see no cardiac activity, then follow-up ultrasound is indicated. Here's an example of embryonic death. You can see early on the gestational sac here is somewhat irregular. The embryonic pole demonstrated here is you have loss of the normal segmentation of the embryonic pole. This is somewhat macerated. Usually by this time you can see the head clearly separate from the body, demonstrated here, and that usually those are seen as two identifiable segments. Here they are somewhat amorphous. Here's another example of embryonic death, and this is a good example of the so-called first trimester oligohydramnios. You see that the embryo virtually fills the entire of the gestational sac here, and there's very little fluid in this area relative to the size of the embryo. Here's another case of embryonic death, or in this case missed abortion, which is the same thing. You can see here's the embryo right here. In this case, this is farther along. You can see most of the bones are ossified, but they are now collapsed in on themselves. There's very little fluid around the embryo, and the fetus has become more macerated and is starting to resorb. Abortion. In most cases, when we're talking about abortion, we're talking about spontaneous abortions, but of course there's also therapeutic and missed abortions. Missed abortion refers to intrauterine fetal demise. This is largely a clinical diagnosis, but there are ultrasound findings that can help you. If you see a gestational sac that is extended into the cervix, that is a strong sign of an abortion in progress. Sometimes a deformed sac or embryo is evident, and almost always these embryos are without cardiac activity. This is an example of an abortion in progress. This is the vagina here. This, of course, is the urinary bladder. This is the cervix. And this would be the external os there. And you can see there's the gestational sac well within the cervix, outlined here, the uterus back here, well within the cervix in this patient with an abortion in progress. What are some of the other findings that might portend spontaneous abortion? Of course, the thickened or calcified yolk sac. Sometimes you will see an intrauterine mass with cystic spaces, which it represents the hydropic degeneration of the residual placenta. Sometimes you'll see just an empty uterine cavity. And then, of course, the BHCG levels should decrease abruptly. Here's an example of hydropic degeneration of the placenta. Here is the area of the placenta right here, and you can see that there are multiple cystic structures within it as this placenta has already started to degenerate. Extrachorionic fluid collections. There are two important things that you need to distinguish from subchorionic hemorrhage. One is the chorioamniotic separation, which is a normal part of development, and the blighted twin ovum, from the subchorionic hemorrhage, which is something akin to abruption. In this setting of chorioamniotic separation, the amnion crosses in front of the placenta and is evident until the 12th or 16th week, menstrual weeks of gestation. In the case of subchorionic hemorrhage, almost always the fluid collection is contiguous with the placental edge and to one side. Here's an example of a subchorionic bleed. Here's the placenta. This, of course, is the embryo here. But you can see here that a margin of the placenta has been lifted up. And then there's all this low-level echoes in this fluid collection to one side. And that is blood, in this case, of subchorionic hemorrhage. Now, one caveat about making that diagnosis is that in normal pregnancy, if you see the amnion here, until that amnion is contiguous with the chorion, which is going to be back here, you'll have a space. It's called the chorioamniotic space here. And at most gain settings at which we scan, this looks anechoic. If, however, you were to turn up the gain level, and here I've done it to an unreasonable degree, the gain level is way up, you will actually see low-level echoes within this chorioamniotic space, and that is normal. There's a jelly-like substance that fills this space, and it will give low-level echoes normally, so do not mistake that for subchorionic hemorrhage. Then the issue of gestational trophoblastic disease. The most common form that you will see is the so-called classic or complete mole, or hydatidiform mole. In this case, fetal tissue is absent, and you'll get a degenerating placenta with hydropic villi and trophoblastic proliferation. About 10 or 15 to 25% of these will go on to develop malignant sequelae in the form of either invasive mole or choriocarcinoma. What does the molar pregnancy look like? Well, it is somewhat variable in appearance. In the first trimester, it can be echogenic or hypoechoic. In the second trimester, we tend to get the expansile echogenic mass with multiple cystic spaces. This is the classic form that you will read about most often, and is sometimes compared to a snowstorm or a Swiss cheese appearance. This is the classic molar pregnancy of the second trimester. Here it is. You can see an expansile mass within the uterus with multiple cystic spaces shown here, here, within it. And here's another example of the same pregnancy, expansile uterine mass here with multiple cystic spaces. This is even a more florid example. Here is the very large uterine mass occupying the entire of the uterus with multiple cystic spaces shown here and here and here, and multiple cystic spaces throughout. Often seen in conjunction with these molar pregnancies is a abundance of cysts within the ovaries, these so-called fecal lutein cysts. You see those in approximately 50% of cases. And they are basically, by ultrasound, large multilocular bilateral cysts. And here's a couple of examples. In a molar pregnancy, you can see that the ovaries contain multiple large cysts on both sides. And here's the one on the other side. If the molar pregnancy is evacuated, and yet the beta-HCG level rises or does not return to normal within 12 weeks, then the assumption is that the woman has an invasive mole. In this case, the molar pregnancy has infiltrated into the myometrium and it still remains within the uterus. With single-agent chemotherapy, the cure rate is very high, nearly 100%. So this is not quite catastrophic, but something that needs to be searched for. Once you have metastases, however, then you're in the category of choriocarcinoma. The metastases could spread to the lung, the vagina, the liver, or the brain. The statistic usually given about these molar pregnancies is about half of them of choriocarcinomas arise from molar pregnancy, and the other half arise in a different setting, possibly ectopic or abortion. There is the phenomenon of a coexistent molar pregnancy and a fetus. This is very uncommon, and one assumption is that this represents molar transformation of one of the twin pregnancies. Often included in discussion of molar pregnancy is the so-called partial or incomplete mole. This is a somewhat unfortunate name because what is really happening here is that you have a triploid karyotype. This is an example of aneuploidy. In other words, you have 3 sets of chromosomes in each cell, and the 3 sets of chromosomes usually are accounted for because 2 sperm fertilize a single egg. There is the case of diovia, where you could have a single egg that is fertilized by a single sperm, but the egg is in the process of division, so you can get triploidy in that way, but almost all of them result from dispermia. The trophoblastic changes are more focal. Embryonic or fetal tissue is present, and there should be no trophoblastic proliferation as you would see with a complete or true mole. There is essentially no malignant potential associated with this entity. This is an example of a triploid pregnancy. This is the fetus here, and you can see that the fetus is dwarfed by this very large, massively large placenta with all these little cystic spaces within it. So this is characteristic of triploid pregnancy: very small growth-restricted fetus, a very large placenta with multiple cystic spaces. So if you see a woman with a positive pregnancy test and a cystic molar appearance within the uterus, this is the differential diagnosis you should consider. It could be a molar pregnancy, it could be a triploid pregnancy or partial mole, It could be hydropic degeneration of the placenta in the case of intrauterine fetal demise. It could be retained products of conception. And occasionally you will get degenerating leiomyomas that can look very similar to this. Here's an example of these things. This is the example of a uterus here, again by endovaginal imaging. And here within the uterus is this cystic expansile mass. And this is a case of a partial mole or a triploid pregnancy. Here's a very similar appearing case. This, of course, is the uterus here. This is the expansile cystic mass, and this is a case of a degenerating leiomyoma. Here's a case very similar in appearance. Here's the uterus again, here, and here's the echogenic expansile mass with multiple cystic spaces. And this is a case of a complete molar pregnancy. And finally, this is the last case, very similar to the one just seen, large expansile uterine mass, multiple cystic spaces, and this too is a complete mole. The final topic I'll take up in this lecture is that of ectopic pregnancy. Ectopic pregnancies are more common than they have been in the past. Almost all of them are tubal in location, but they aren't exclusively tubal. You can also have abdominal pregnancies, ovarian ectopics, and cervical ectopics, but these are quite rare. There are many risk factors associated with ectopic pregnancy, importantly infection, pelvic infection, prior ectopic, or a history of some sort of pelvic surgery. Here is a drawing of ectopic pregnancy. As is said, almost all of them are tubal pregnancies, that is, the pregnancy is lodged in the tube as it is here, but they can also occur in the cervix, demonstrated there, or in the ovary, demonstrated here. Even more rarely, the ectopic pregnancy can be outside the GU tract and be an abdominal pregnancy. There's an important subset of tubal pregnancies called cornual or interstitial ectopics, and that's when the ectopic pregnancy is lodged at the cornua of the uterus. So there are specific ultrasound findings in the assessment of ectopic pregnancy. There is, of course, the unruptured live ectopic that you can see in the adnexa, or you could see an intrauterine pregnancy, which virtually excludes the possibility of a coexistent ectopic. The odds against having both an intrauterine and an extrauterine pregnancy are very small, except in patients who are undergoing ovarian ovulation induction or infertility treatment. Here's an example of an ectopic tubal pregnancy. This is the uterus transabdominally. We're looking through the urinary bladder here, and right here is the ectopic pregnancy seen out in the left adnexa. Here's an example of a cornual pregnancy. These can be difficult to diagnose, but what's important about them is that they are always very eccentric in the uterus. This is the contours of the uterus here. This, of course, is the endometrial stripe. The other thing that's important about them is that there's very little myometrium laterally, and the endometrial stripe ends directly onto the gestational sac. That's called the interstitial line sign. Remembering that the endometrium, or the uterine cavity, would wrap around the gestational sac normally, and that would produce the double decidual sign. So here's an example of why that happens. The endometrium comes right up against the uterine. The endometrium comes right onto, ending in a blunt T junction, onto the gestational sac. Here's an example of an ectopic pregnancy that is so abnormal that it's actually quite easy to mistake. This is a transabdominal scan through the urinary bladder here. This is the uterus outlined here, and the gestational sac is clearly extrauterine, and in fact is outside the GU tract altogether. This is an abdominal pregnancy. What's important about this diagnosis is the identification of the uterine cervix. So the way you would diagnose this is that you identify the uterine cervix and follow the endocervical canal up into the uterus, and that will show you that this is outside the uterus. and not within it. So it's very important to always locate the cervix and be very clear how the endocervical canal joins the endometrial cavity. Here's an example of an ectopic pregnancy in the left adnexa. This is the area of the uterus here. This is the broad ligament. This is the left ovary over in here in this area. And here's the ectopic pregnancy right there. What's important about this is notice that the tubal pregnancy in this case has an echogenic ring around it. This is the so-called adnexal ring sign, which I'll talk about in a minute and is very useful. The exception to the intrauterine pregnancy rule, that is, that it's very unlikely to have both the intrauterine and extrauterine pregnancy, is the so-called heterotopic pregnancy, seen almost exclusively in the setting of ovarian induction or infertility treatments. Here's an example of scanning into the right adnexa, and you can see one gestational sac here, and then if you scan over the uterus, demonstrated there, you can see that there is an intrauterine pregnancy as well. So this is called heterotopic pregnancy, and it does occur rarely. Again, because this woman in this particular case was undergoing ovarian induction, she had not just one intrauterine sac, but two. There's one, two, as well as the ectopic pregnancy. Notice that in the posterior cul-de-sac, there's a lot of fluid here with low-level echoes constituting blood. If you look up high into the flanks, you'll notice that there's blood also in the hepatorenal space, indicating that this woman has quite a lot of blood in her abdomen and pelvis. So there are strong but not specific ultrasound findings of ectopic pregnancy. One of the most important is the so-called adnexal ring sign or tubal ring sign. This is very important because the positive predictive value is very high in the setting of a positive pregnancy test and no intrauterine pregnancy. I should say that corpus luteal cysts can sometimes look like this, but in that case you should not, the woman in most cases would not be pregnant. The reason why you have the tubal ring sign or the adnexal ring sign is that the echogenic trophoblastic tissue lines the tube, and as you cut across that tube then you will get this sort of round echogenic donut. There's a large amount, the other signs of ectopic pregnancy are a large amount of fluid, and by fluid I mean blood, within the abdomen or pelvis, and in many cases you'll see the low-level echoes indicating that it is complicated fluid, not simple ascites. Here's an example of the adnexal ring sign. Here you can see this very echogenic ring that surrounds the gestational sac here out in the adnexa. So if it's setting of a positive pregnancy test, no intrauterine pregnancy, this is a very potent sign. Here's an example of free fluid. In this case, you see a relatively small amount of fluid here in the posterior cul-de-sac, but it does have low-level echoes. But there is an abundance of fluid up in the upper abdomen, so to remind you and to warn you that the woman can have a lot of blood in the abdomen that is localized superiorly in the abdomen and will not be evident necessarily if you look only at the pelvis. Other signs of ectopic pregnancy, complex adnexal masses. The positive predictive value of that sign is actually less than that of fluid, and the reason for that is that there are so many reasons that young women might have complex adnexal masses, including tubo-ovarian abscesses, endometriomas, ovarian masses, or dermoids. But if you have the combination of adnexal masses and free fluid, then the positive predictive value in the proper setting is quite high. Occasionally you'll see reference to the decidual castor, the pseudogestational sac of pregnancy. And this, the pseudogestational sac occurs in the setting of ectopic pregnancy and represents a sloughing of the decidua into the uterine cavity. Here is an example of that. Here is the ectopic pregnancy here out in the adnexa, and within the uterus, demonstrated there, you have a small amount of fluid that could be feasibly mistaken for a gestational sac, but simply represents a sloughing of the decidua within the uterine cavity. Importantly, you will not see the double decidual sign in this setting. Remember that the finding of having a normal pelvic study does not eliminate the possibility of ectopic pregnancy. The presence, clearly some 5 to 30% of women with ectopic pregnancies will have a completely normal appearing ultrasound study. Some people have advocated the use of Doppler ultrasound in the diagnosis. I personally have found this of limited usefulness, but the claim is that you will see low resistance blood flow in the area of the ectopic pregnancy. This is an example of this low impedance flow characterized by a high end diastolic velocity. And to remind you that ectopic pregnancy is diagnosed both by ultrasound and by other factors. So if you have a serial beta HCG level and it does not increase as much as 63%, or the doubling time is somewhat less than every 2 days, then the possibility of ectopic pregnancy must be considered very seriously. So in summary, something is very wrong in the first trimester if you find these signs. These are the signs that are most important. If you have a mean sac diameter that is 8 millimeters or larger and you do not see a yolk sac by transvaginal imaging. If you have a mean sac diameter of 16 millimeters or greater and you don't see an embryo. If you see a fully formed amnion but no embryonic pole. If you do see a heart rate within the embryo, but the heart rate is less than 100, and some people say less than 85, then the chances of a viable pregnancy is much less. If you see a thick or calcified yolk sac. If you see evidence of first trimester oligohydramnios or very little fluid around the developing embryo. If you have no cardiac activity and the crown rump length is 5 millimeters or greater, the chances of having a viable pregnancy are vanishingly small. And finally, if you have a positive beta HCG and no intrauterine pregnancy is evident by transvaginal imaging, especially if that HCG level is 2,000 milli-international units or greater, then the possibility of ectopic pregnancy becomes very high and something to be considered seriously. So that is a kind of overview of first trimester pregnancy. We talked about the approach to diagnosis, some normal landmarks that you would expect to see at predictable times. I categorize certain signs as strong, less strong, and weaker signs of abnormality. And then we talked about how these signs can be applied to sonographic images in the diagnosis of specific abnormalities of first trimester pregnancy. Thank you.